Hello, and thanks for joining us. My name is Mark Bierce, and I'm the Program Director for the Bioidentical Hormone Initiative. I would like to welcome everybody to today's live interactive educational webinar, Emerging Concepts in the Diagnosis and Treatment of Hyperthyroidism. This is the third and final installment of Dr. Holtorf's presentation. Archived recordings of the previous webinars can be found on the BHI website, www.bioidenticalhormoneinitiative.org/webinars. This webinar is brought to you by the Bioidentical Hormone Initiative. BHI is a community of physicians dedicated to the treatment of age-related endocrine dysfunction with bioidentical hormones and other evidence-based integrative therapies to improve quality of life, prevent chronic illness, and obtain optimal health. If you would like to receive notifications of future webinars as well as other BHI events and educational programs, please register at our website. I also want to mention that we're very excited to announce the first annual BHI Symposium coming this weekend in beautiful Madison, Wisconsin. The subject is evidence-based approaches on age management, growing a successful BHRT practice. If you'd like information about the event or you'd like to register, please go to our website and you'll find the appropriate link to click through. Today's webinar will run approximately 60 minutes. If you're unable to stay for the duration of the webinar, it will be available on our website for viewing. We'll try to devote the last 15 to 20 minutes of the webinar to answering your questions. You can submit questions at any time during the webinar by typing your question into the box, the webinar control panel on the right side of your webinar screen. Now about our presenter, Dr. Holtorf. Kent Holtorf has personally trained numerous physicians across the country in the use of bioidentical hormones, hyperthyroidism, complex endocrine dysfunction, and innovative treatments of chronic fatigue syndrome, fibromyalgia, and chronic infectious diseases, including Lyme disease. He is the medical director of the Holtorf Medical Group Affiliate Centers, the medical director of the nonprofit National Academy of Hyperthyroidism, and was the founding medical director for fibromyalgia and fatigue centers. Dr. Holtorf is a diplomat, board examiner, and fellowship lecturer for the American Board of Anti-Aging Medicine and the endocrinology expert for America Online Health. He is a founding director of the nonprofit Bioidentical Hormone Initiative that is bringing you today's event, and he's also a senior faculty member at the Initiatives Institute. If you would like to find any of the references to investigate further Dr. Holtorf's presentation today, the references can be found at the website for the National Academy of Hyperthyroidism, www.nahyperthyroidism.org. And if you'd like to discuss today's topic or other topics, please note that you're welcome to register at the BHI website and participate in the BHI forums. There's a forum on today's topic of hyperthyroidism as well as a number of other interesting topics. We welcome your participation. So now, without further ado, I'm going to turn the webinar over to Dr. Holtorf. Dr. Holtorf, thank you for joining us.
Thanks, Mark. Appreciate it. And
it will take me one moment to give you control. Okay, Dr. Holtorf, it's all yours.
okay, thanks so much. And this is, as Mark said, part 3. In part 1, we looked at the basics of thyroid physiology and reviewed a lot of studies showing that the TSH is a very poor indicator for the tissue level or the metabolic effect of thyroid in the body. We also looked at in detail deiodinase activity, how important the local control of thyroid is, just not what's in the serum, but what deiodinases, again, convert T4 to T3 or T4 to reverse T3. We reviewed all those studies. And then in the second part, we looked at specific conditions that that cause the standard blood test to be inaccurate, including depression, chronic fatigue syndrome, fibromyalgia, diabetes, any chronic infections, chronic inflammation, weight loss, dieting. So all those things resulted in the TSH being an unreliable marker for the tissue level of thyroid. We also looked at, in part 2, thyroid transport, which is a very important concept and rarely discussed. It is the rate-limiting step of basically the thyroid activity. So because what's in the serum is not necessarily what's in the cell, and that's where the thyroid has activity. So in this part, we'll move on to looking at more, how do we diagnose? In part 2, we looked at some other markers for tissue level activity. So we're going to kind of get to more of the clinical, what do you do now? Okay, you know these things are inaccurate. You have some basic blood tests. What else can you do, and how do you treat? So here was an original case that we presented in part 1. A 42-year-old woman comes in complaining of inability to lose weight, ongoing depression on antidepressants, fatigue, and muscle pain. She has been diagnosed with fibromyalgia, bipolar depression, and type 2 diabetes. She's on metformin and Effexor and Vicodin for pain, and also on Lipitor. She tried numerous antidepressants and lyric without benefit. So she's a TSH of 1.2, a free T4 of 1.7, and a free T3 of 2.7. And I would think that most people, kind of, would say, oh, the person probably has normal thyroid. But hopefully after watching the first 2 sections, you say, what's the chance of this person having low thyroid contributing to their symptoms? Probably close to not 100%. Nothing's 100%, but 90+% chance that this person has low thyroid. Why is that? Depression. So we looked through all the studies showing that depressed patients have a low TSH, actually a higher T4, a low T3, and a high reverse T3. So they don't transport the T4 into the cell, so they have their cellular hypothyroidism. Fatigue, the same thing. We looked at those studies showing that even people with just fatigue in normal levels, one study did a thyroid biopsy, and majority of those had thyroid inflammation, and they responded regardless of the blood levels. Muscle pain, fibromyalgia, they're all low thyroid. And doing TRH testing, they basically 100% of patients have low thyroid, a secondary hypothyroidism. So they have a low TSH, but if you do a thyroid-releasing hormone test, it's shown to have low thyroid, despite standard tests being normal. Bipolar depression, we looked at the study showing that 160 patients with treatment-resistant bipolar depression that were on average of 14 different medications without any effect, and 80% got significantly better and 30% total remission by just giving T3. Type 2 diabetes, we looked at those studies showing they have between a 20 to 50% reduced T4, T3 conversion. So again, they have cellular hypothyroidism. So all those things would indicate that person is low. So what's the chance, again, this person being low? Very, very likely. So but let's look at what, okay, you have that, this person's low, but what else can you do to evaluate her thyroid function? Okay, well, we talked about how it's important that really, look at symptoms. Look at, the big problem is, we learn in medical school, treat the patient, not the blood work, but what does everyone do when they get out? They quickly look at the TSH, you're fine. Or they'll go to a, university endocrinologist, they won't even see him because their TSH is normal. I mean, and the doctors have, become glorified lab techs. They've lost the ability to think and evaluate the patient clinically. So that's important. But there's also other laboratory objective markers as well. And also we look at signs. We look at the, you can use the reflex, the ankle reflex, or the thyroflex, which gives you an objective marker for the relaxation speed of the ankle reflex or brachioradialis reflex. So shown to correlate with symptoms better than serum levels. So it's measuring tissue level. So you have a slow relaxation phase. Again, TSH, just get a TSH because the TSH, if it's high, it's very specific. Has very poor sensitivity, but is specific if it's elevated. So if a TSH above 2, they're low thyroid. Free T4, not a great marker because we talked about that when you inhibit thyroid transport with any inflammation, again, dieting, diabetes, all those conditions that we talked about, T4 is not transported in the cell. It's much more energy dependent than the T3 transporter. So T4 can actually go up when you have low thyroid. You'll see that in particular with depression. So they'll have high T4, low TSH, and we talked about the studies will say, oh, they're subclinically hyperthyroid. No, they're hypothyroid. They'll have a low T3, a high reverse T3. So they basically have cellular hypothyroidism. So free T3, a better marker. Reverse T3. Now, reverse T3 is a marker, and it also has an effect. So we talked about that because of the thyroid transporter for T4 and reverse T3 are either the same or have the same pharmacodynamics that in pharmacokinetics, that if you have high reverse T3 in the serum, it is contributing as that T4 to reverse T3 conversion that's increased, but the bigger contributor is the reduced reverse T3 transport into the cell. So the serum level goes up. Now, why is that important as a marker? Because now you know if you have high reverse T3, it means that the T4 transporter is not working very well. It's deficient. So anytime you have high reverse T3, don't use T4. And it's also showing that the TSH is not reliable and the not reliable marker for the tissue level of thyroid. And again, the pituitary has completely different deiodinases and different transporters that aren't affected by the same things as the rest of the body. So it's probably the worst tissue to use as a marker. That's what we use primarily. TPO, antithyroglobulin, look for autoimmune thyroiditis or Hashimoto's. Again, talked about the study where majority of people were fatigued, had inflammation of thyroid, but the 2 antibodies we checked two. There's hundreds were negative. But if you see that, it will be high. And if someone has Hashimoto's, you should very much treat it, even if they're so-called normal, because even just the inflammation will reduce cellular thyroid levels. They're knocking off part of their thyroid. Now, what you'll see, too, though, is some people, as they're not killing off their thyroid, so that's lowering the thyroid in the long run, but it's also dumping thyroid in the system. So people with high antibodies, they'll have symptoms of high and low. So you really want to kind of knock those antibodies down so you get a much steadier level so you can treat. Ways to do that, low-dose naltrexone is great. Can really reduce about 4.5 milligrams. Take that will modulate that immunity. It works great for a lot of autoimmune diseases. Just giving selenium will lower antibodies. The Journal of Rheumatology showed by 40%. We use a product called ThyroRx, which is at holtorf.com. But also testosterone. You want to make sure their DHA testosterone are adequate because those will lower autoimmune disease and that modulate the immunity. That's why men have a lot lower incidence of autoimmune disease. SHBG. So again, we talked about this, but SHBG again goes up in response to the liver to 2 things primarily: estrogen and thyroid. So if someone has low SHBG, let's say it's a better marker in women, if their SHBG is below 80, you know they're either low estrogen and or low thyroid. And so if you evaluate their estrogen levels and their estrogen production, if you find that that's where they're replaced to a normal level, then if they're still low, then you know they're low thyroid. And also if you give thyroid and the SHBG doesn't go up, you know they have thyroid resistance, which we talked about in part 2. And also, when you're giving oral thyroid, it just says oral estrogen. You take a birth control pill, SHBG goes very high. And that's used to treat, let's say, acne, because as high SHBG will lower the free testosterone. So same thing with giving thyroid. You're giving thyroid orally, goes in the liver as a higher level. So you should really have above, at least a high normal or higher SHBG. If you don't, some other thing to think, hey, am I giving enough thyroid here? Leptin. We talked about leptin in the previous lecture, that leptin goes up when you gain weight, tells the body to stop storing energy. But people who are obese for a period of time will typically get a leptin resistance. And the body doesn't see it, so the brain thinks the body's starving. So it tries to lower thyroid, lowers metabolism, increases appetite. So, but also leptin needs to make TSH. So if you have a high leptin, generally above 12, your TSH, again, is not reliable because it's going to be lower than it should be for the same level of thyroid hormone. Iodine. So iodine's needed for a couple things. It's needed to produce thyroid. And so low iodine, you're going to not produce much thyroid. But it's also it's needed for thyroid activity. So you'll get the people with low iodine, they basically have a thyroid resistance, much like iron. So if comes to give them iron, or excuse me, iodine, and all of a sudden their hands are warmer, like, oh my gosh, the thyroid finally started working. Cortisol, you want to make sure their adrenal function is adequate. That will, all the hormones influence each other. So especially if someone doesn't tolerate thyroid, another thing to look at is their cortisol level adequate, and is their progesterone level adequate, and also magnesium. Growth hormone, IGF-BP3, so IGF-1, IGF-BP3, look at their growth hormone status, also influence C-reactive protein. And we looked at these studies, even in the normal range, even up to 2, a direct correlation with the higher the CRP. Even in the normal range, the lower the T4, T3 conversion, and lower serum levels of T3 and lower T3 transport and T4 transport. So any inflammation is going to reduce that cellular transport and conversion inside the cell, even though the standard blood tests will look normal. It actually suppresses the TSH, even though the levels are lower. Iron, so check your iron status with ferritin as well and saturation, because with low iron you get a number of things. You get a thyroid resistance, you get a reduced T4, T3 conversion, and you basically get, it blocks downstream activation of thyroid, so causing the thyroid resistance. So people with low iron will be oftentimes fatigued, even though their blood levels are fine. So it's not really a problem with oxygen carrying capacity. It's a problem with thyroid activity. Vitamin D also goes along with the autoimmune. Make sure the autoimmune patients have adequate vitamin D. And basal metabolic rate. So we check everyone's basal metabolic rate when they come in, and people go, oh, I have no metabolism. People go, oh, sure, you don't. And you check it, and they're 30, 50% lower than they should be. And they're eating 1,000 calories a day and gaining weight, but people don't believe them. And so look at, we'll talk about T4, T3, free T3, reverse T3 ratio. So individuals can suffer for years being told their thyroid's fine, but more specific testing will often reveal that the thyroid's low. Often remarkable results, and these patients just go for years just, oh my gosh, I'm fatigued, I'm depressed, they keep getting put on antidepressants that don't work when you're low thyroid, and treating these patients, you're just going to have a huge following of very happy patients. So the typical symptoms: fatigue, depression, difficulty losing weight, chronic fatigue syndrome, fibromyalgia, hair loss, all those things can be completely reversed. So what do you treat with? So the standard is T4, which is Synthroid or Levoxyl, Armour, which is T4, T3 combination, 30 micrograms of T4, 9 of T3. So it's mainly T4. There's compounded T4, T3. There's Spirolar, which is difficult to get. It's a little higher ratio of T3 to T4. There's the standard Cytomel, which is T3, short-acting, and time-release T3, which we mainly use. We'll talk about the benefits of all those and compare them. So, this is the whole thing. It's so funny with the, you go to the, endocrinology meetings, and it's just, everything's Synthroid. Oh, people don't need it. My patients don't need it. Well, you must be not talking to your patients. So someone says, what's the best form of T3 replacement? Okay. So let's look at that. Is it Cytomel? Is it time-release T3? You'll hear that time-release T3 doesn't work. And there's some truth to that, because the standard formula that's used by most compounding pharmacists doesn't absorb very well in a number of patients, especially if any gut issues with leaky gut or low digestive enzymes. Oftentimes it's just they're using 5 times as much compared to Cytomel. But there is a trade-off. If you're going to just make something time-release, it will bind some of the T3 up. But the problem is the standard formula just binds it all up. So there's different ways to make it that you'll find the time-release T3 can work much better, and you get the benefits of time-release versus not having to use excessive amounts. So thyroid hormone action is genomic, so it's inside the nucleus. Thyroid must go into the cell, into the nucleus, and bind to the DNA receptors and change protein synthesis. So it's actually a slow process, and basically, so it's kind of over time feeding into the system. So really, based on its main effect, the steady state, the steady level, doesn't make that much difference. Okay, so because you're modifying the mRNA translation process, so fluctuations don't make much difference in terms of that effect. But there's also non-genomic effects, which interact with the plasma membrane and affect ion pumps and channels, especially the heart. So that's the big problem with short-acting high levels. where the, like with cytomel, goes up high. It's not the effect. You can get the effect, but it's basically this other non-genomic effect where you get the side effects. And that's independent of the nuclear effects. And so a number of studies there. And as you'll see, if I mention, if I have a couple references, they'll be on there. If it just gives numbers, then it's available on the particular review on National Academy of Hypothyroidism, the nonprofit, nahypothyroidism.org. So the major non-genomic actions include activation of the cardiac, sodium, calcium, potassium channels, increases cardiac contractility and heart rate. The stable serum T3 is important to reduce these cardiac effects. So it's not so important, again, with the major effect, but it's these problematic side effects, which are actually separate. You know, you can use cytomel, TID, QID, but you know, anytime you use something multiple times a day, the compliance goes way down. So when you use when you make a time-release T3, there's methicillin in there, and the problem is it will bind up some of the thyroid to make that time release. So T3 is less potent. A compounded T3 is less potent than cytomel, so they're not interchangeable. But again, the problem is that some of them are so have such a reduced potency because they're the way that they're formulated that they say, oh, they just don't work. But you just need higher and higher doses. But if you're giving someone 300 micrograms of T3, it doesn't look good, and someone's going to it's going to draw red flags. So there is a trade-off for appearance of high dose for steady levels, but you can get it close to the potency of close to potency, but but it's not going to be totally equal. But you can get it close. Okay, armor. Let's look at armor versus compounded. Now, the problem with armor is it's pig, so you can get some antigenicity to it, and it's more anecdotal studies, but can contribute to autoimmune thyroiditis potentially. Potency variability. I think this has been overplayed, but I'll show you a study. Was said that it was it's totally variable. It's an old old technology, old drug, and so all the endocrinologists really put it down. But you look at a lot of the problems have been in with Synthroid potency. The problem is it's a fixed ratio, so you can't really adjust if you want to use more T3 or less T4. Now, T3, T4 secretion for thyroid is about 10 to 20% of T3 compared to T4, depending on the condition of the person. Now, the natural desiccated thyroid is a little high at 23, so you say, oh, it's not natural. But here's the problem. Again, we're clinicians. We're intervening. So you don't, it's like saying, well, just let the body do what it can with it. The body's not doing what it should because of all the inflammation and chronic illness. So it's not converting the T4. So you can't just give a normal amount of T4. It's like saying, well, just give the body cholesterol. It will make all the hormones. It knows what to do with it. You can't do that. So we really want it to be customized for the individual. The best preparation is what works best for that patient. And patient satisfaction. So we find that compounded, you have much higher patient satisfaction. You're able to customize it for that patient, whether you want to do straight T3, you can just a little more T3 compared to T4 for that particular patient. With insurance, and the problem is with with insurance medicine, everything's just mass medicine, and so really to practice good medicine, I think it's really impossible to take insurance, spend time with patients and not get in that grind. And really increases when you're doing custom medications for patients. That's really, you're going to have that patient for life. You're doing the best medicine for them. Really involving the patient as well. So it really builds a relationship. You don't want to just give, again, the stock medicine kind of one size fits all. It just doesn't work as well, and you're not going to have happy of patients. So here's a study. Now this is in JAMA, and JAMA is probably the most biased piece of journal I've ever seen. Before that, any article comes out, like you can tell exactly what the conclusion is going to be before it comes. It's so politically motivated. But maybe that's a little harsh. But study of the generic desiccated thyroid preparations. They looked at T4 contained between 15 to 120% of stated T4 and T3. So you look at here, they checked these. These were generic desiccated thyroid, 1 grain, and some had 50%, 117%, 93%, 73%. So you can see that in some of them there were 15%. So highly variable. But again, this certainly is a suspect article. And so again, can be significant differences between compounding pharmacies, and you don't want to having patients go to multiple pharmacies. You'll find that all of a sudden they're doing well, and now their levels are totally different, and they're crashing. The PCCA formula, PCCA is a good service, but their thyroid preparation, their formula just doesn't work very well. So a number of pharmacies are turning to the evaporation constant uniform dissolution method, which is allowing a much better bioavailability of the compounded time-release T3. So we currently use American Integrated Pharmacy, and I was told Restore Health Pharmacy also is starting to use this, and also in-house dispensaries. So you can basically do compounds, compound the medication right in your office, and that's what we do with all our franchises. So patient call and ask you, what's the equivalent dose of T4, T4, T3, and T3? Okay, so they're on Synthroid. They say, how would you convert them? What's the equivalent dose? So what do you tell her? Now this is what's listed in the PDR. It's listed that 1 grain, which is 38 micrograms of T4, 9 of T3 is equivalent to 100 micrograms of T4. And so is that, does that make sense? If it were, then T3 would have to be 6.9 times the potency of T4. Okay, so it is not. And what is the potency of T4 compared to T3? You'll hear 4, you'll hear 5, but that makes no sense. If you look at the average conversion of T4 to T3 is 40 to 50%. So just based on that, if you give T4, it should be 2 times of T3. So it's not counting the fact that you look at there is conversion. So that is totally incorrect. So this is what happens. The doctor, the endocrinologist or doctor goes, patient goes, I want to be on Armour. No, Armour's old, it's not going to work. So they're on 100 micrograms of T4, they put them on 1 grain of Armour, and they feel terrible, and they go, see, I told you, and they go back to Synthroid. Because they just underdosed the patient. And that's also in those studies, and we'll look at those, where they prove that T4, some of the studies show that T4, T3 patients feel better than T4. But they went back and repeated the studies, and basically substituted 10 micrograms of T3 for 50 of T4, and said, see, the patients didn't feel any better. Well, their TSH went up, you basically just gave them less thyroid. I'm surprised it didn't feel worse. So really, again, those studies were made to fail. So again, if T3 is 4 times as potent, 1 grain would equal to 75. And if 2 times, which is really more of the correct, and also you got to realize that time-release T3, again, it's going to be less potent than Cytomel. So if someone's on, let's say 100 of T4, think of at least 50 micrograms of time-release T3. And in 2 grains of T4, T3. So really, Synthroid in the box will become the standard because of marketing. And the use of these preparations will result in inadequate treatment for the overwhelming majority of people. We find most patients, the majority, feel better with straight T3. Some don't need total all T3, but T4, T3. And generally, when do you decide to use T3 versus T4, T3, or T4? If a person is totally healthy, no stress, not overweight, doesn't diet, no medical problems, then T4 may be okay for them. But as they get sicker or more stressed, they need more T3. And for your sickest patients, chronic fatigue syndrome, fibromyalgia, depression, diabetes, for weight loss, for if they've been significantly yo-yo dieting, they're going to need all T3. And just a quick, do not give thyroid for weight loss. You're not doing that. But almost everyone who's trying to lose weight has low thyroid because the body is, again, compensating. It starts, once you diet, starts lowering all your tissue thyroid levels, so they're low thyroid. So you're treating low thyroid, you're not giving thyroid for weight loss. So again, they're not optimal for people with chronic fatigue syndrome, depression, chronic illness, diabetes, weight gain, because they have reduced T4, T3 conversion and the reduced uptake of T4 in the cell, and thyroid resistance. And so, they're not taking T4 up in the cell. Why give it? So again, this study here, Journal of Clinical Investigation, looked at whether or not tissue regulatory mechanisms provided normal T3 concentrations simultaneously in all tissues in hypothyroid animals receiving T4 only. So you can't do this in humans, but what they did was they gave basically animals, they took out the thyroid, gave them T4, and basically cut up the tissues and said, okay, what's the tissue level? They found they made the plasma, TSH, T4, and T3 levels, and 10 different tissue levels of T4 were measured. So they measured all the thyroid functions and the tissue level of thyroid. They also measured the deiodinase activity. So they demonstrated that all tissues, except for the pituitary, required supraphysiologic levels of plasma T4 to maintain proper levels of T3. The exception of the parts of the brain, the pituitary, all the tissues were hypothyroid, but the pituitary was not. So again, the pituitary can compensate. So the TSH looked fine as the rest of the body was starving for thyroid. So the pituitary, again, the T3 levels of the pituitary were fine, so TSH was normal, but the rest of the body was low. So the study showed you're not able to achieve normal levels by just giving T4. So we had some amounts of T4 infused. The level of thyroid hormones in the pituitary were over twice that of other tissues, because the pituitary, again, has different deiodonases, different transporters, and it can tolerate just T4 and these low levels of thyroid much better than the rest of the body. The dose of T4 normalized T4 and T3 were insufficient to normalize concentration of T3 in most of the tissues. So, even if they had normal serum levels, the tissues did not have normal T3 levels, except for the pituitary. So again, why do we use the TSH? It's the worst tissue to use. So here's the author stated, it's evident that neither plasma T4 nor T3 levels alone permit the prediction degree of change in T4 T3 concentrations in the tissues. Not only the tissue to plasma T4 and T3 ratio is different for different tissues, but they may also change for a single tissue as a function of plasma iodothyronine level. So, this is what happens. So again, we talked about local control, but different tissues get different amounts. And it can genetic and also change with different conditions. So that's why some people are low thyroid, they get fatigue. Other people have hair loss. Other people have cold hands, cold feet. Other people will get fibromyalgia. Other people have everything. So it depends on what tissues that's able to bring in the thyroid. It's clear for the present results that a normal thyroid status is not achieved simultaneously for all tissues when T4 alone is infused. Current therapy of hypothyroidism should no longer be considered adequate and might possibly lead to the development of new strategies of therapy combining administration of both T4 and T3. So here, this study here, okay, they substitute, again, 50 micrograms of T4 with, mine's cut off there, I think it was 10 of T3. The T4 group had significantly improved mood, psychological function, general overall health and well-being, mental health, vitality, depression, anxiety, improved results on a number of depression scales. No different side effects except increased palpitations in the T4-only group. So when comparing the quality of life and depression on T4 monotherapy versus T4, T3 combination therapy, significant difference were seen in 7 out of 11 scores, indicating the positive effect related to combination therapy. This was a study showed, hey, people should be using T4, T3. And which is surprising, again, really they were underdosed because they just gave 10 micrograms of T3. We're trying to get this off. Study published in New England Journal of Medicine substituted 12.5 micrograms of T3 for 50 micrograms of T4 in 33 T4 treated patients, performed a variety of cognitive, mood, and physical tests. They include patients with hypothyroidism. Partial substitutes of T3 for T4 may improve mood and neuropsychological function. 20 patients said they preferred T4 plus T3. 11 had no preference either way, and only 2 preferred T4. The 20 patients who preferred T4 plus T3 reported they had more energy, improved concentration, and just felt better overall. Thank you. And what they'll find, too, is you look at these studies, and they'll say, oh, patients felt better on it, and the conclusion will be, oh, no notable difference were seen, no objective measures. Well, what about how the patient felt? So this study here substituted, again, 50 micrograms of 50 of T4 with 10 of T3. The T4 T3 group had lower T4, which you'll see when you give T3 higher cholesterol levels, lower SHBG, and TSH increase of 1.5 to 3.5. So again, they made them hypothyroid. Their cholesterol went up. Lower SHBG we talked about as a marker for tissue level. And they found it didn't make a difference because, again, they gave him less thyroid. TSH even went up from 1.5 to 3.5. So here's the another study here, and that they found, again, 10 micrograms of T3 for 50 of T4. There's no physiologic basis why they're using that, again, that replacement. Those had, T4, T3 had improved depression, mood, anxiety scores at 3 months, and even though they made them hypothyroid. But then this is what it says. It says no conclusive evidence of specific benefit for substitution of T4 by T3. You know, what about the improved mood, depression, and anxiety? See, they don't count that. So osmothyroid replacement, how do you do it? Well, what do you basically give? So if you're going to give T3, and when do you give T3 again versus T4, T3? Again, the sicker the patient, reverse T3. If the reverse T3 is above 200, I would consider more doing straight T3. You can always also give them T4, T3, and then switch them over to straight T3. But you want to start low because some patients can be very sensitive, usually 10 micrograms for 10 days and 25 micrograms for 10 days up to 37.5. And then you reevaluate. Again, look for, you can check blood levels. Now, once you suppress the TSH, we're going to talk about that, there's no reason to keep checking it. So you want to check a T3, but don't just go by blood levels because, and when do you check the lab? Well, you can kind of make the lab whatever you want. Let's say you give Cytomel, which I don't recommend, but you check it 2 hours later, it's going to be 5 times normal. But then you check it 10 hours later, it's going to be very low. So how is that helping you? So once you're on T3, really any compounded, you can follow it better, but the labs aren't as indicative. It's harder to measure, which is one reason that doctors are a little uncomfortable with it. But you got to be a doctor. You got to look at the patient, evaluate the patient. Labs are a piece of information. Look at the pulse. So the heart is sensitive. So watch the pulse. If the pulse is low, then you can look at the other things. Does this person need more thyroid? But if their pulse is high, you don't want to just keep going up. Sometimes the people with thyroid resistance, that they'll need more thyroid, they feel better, but their heart's racing. So sometimes you have to not give them optimal amounts, and you can sometimes give a little beta blocker. We have a product called CardioCalm. Can help, but you don't really want to, you can get yourself in trouble doing that. So watch the pulse, watch their symptoms, and again, check labs, but don't just go by labs. You got to look at the patient, evaluate them overall. If they have any risk for coronary artery disease, when you start lower, it's fine to start lower and go up. You might want to get a stress test or a calcium score, the heart scan, highly recommended. Now, but the thing is, you look at the risk of causing a heart attack with thyroid is very, very low, even if their pulse goes up, because it dilates the vessels. And you look at the studies, if you give them thyroid during a heart attack, they get less actually cardiac damage because it actually dilates the vessels, get more blood into those areas. So people with low thyroid during a heart attack, they're going to have more damage. So it's kind of opposite of what you think. T4, T3 basically start at half grain, then go up to 1 grain, maybe 1.5, or lower. Now, we'll talk about AFib, risk of AFib, which is totally overplayed. But if someone's older, be careful about suppressing, over 60, be careful about suppressing the TSH because, well, actually, low thyroid increased risk for AFib, but so does high thyroid. And you don't want to get blamed for it. So just be careful with anyone who's at risk, especially with hypertension or enlarged heart. So just based on symptoms and serum levels, so you can look at the SHBG. It's another piece of information. Basal metabolic rate is a great marker. Hey, if they're that's the overall. Basically, their thyroid is your metabolism. So according to metabolism, so if someone has low metabolism, let's say, or their TSH is suppressed, and their metabolism is 30% lower than it should be. Oh, you made the person hyperthyroid. Their pulse is 60, they can't get out of bed, and their basal metabolic rate is 30% lower than it should be, which is crazy. But again, the doctors don't evaluate the patient, they'll just look at one little test. Relaxation phase of the ankle reflex. Again, nice objective marker for tissue level thyroid. Do not increase that has significantly elevated pulse. Do not adjust based on serum levels. Always think clinically, but support it with testing. And don't give thyroid without doing the blood work. And because, one, even if you know the person's low thyroid, because what happens if they do have a side effect or get criticized for just giving thyroid haphazardly, you need to go through the process, evaluate the patient. So, God, I know you're going to be low thyroid, I'll tell you. Even if you do the basal metabolic rates are low, the thyroid effects are low, wait until you get blood levels. Because once you treat them, it's going to mess up the levels. You're going to lose that chance to get to the baseline, which is most important. So check full thyroid panel until TSH is suppressed, and only check the free T3 and SHBG and those other things. Now you want to check a baseline NTX if they're perimenopausal or menopausal, because to show that they're not breaking down bone. Because we'll talk about bone loss, that thyroid in a premenopausal woman doesn't cause bone loss. Postmenopausal, most studies show no. Occasional studies show yes. But if you replace them with estrogen, especially also with vitamin D, and balanced hormone replacement, there's no bone loss. But you want to prove it. So if someone challenges you on that. Now, SSRI is a much bigger risk and bigger cause of osteoporosis than thyroid. And, of course, no one says anything about that. But you'll find that people on SSRIs will have a lot of bone breakdown. So here's just a couple articles. TSH may not be a good marker for adequate thyroid hormone replacement. I won't read that there. But British Medical Journal investigated the role of monitoring biochemical tests of thyroid function in patients receiving thyroxine replacement. So they looked at, hey, okay, well, given this patient's thyroid, how accurate is the standard thyroid test? So prospective study, 148 patients, used a battery of clinical parameters. They found TSH was a poor measure for the estimated metabolic severity of primary thyroid failure. The most accurate was the clinical score and the ankle reflex time. And this is British Medical Journal, so major journal. Measurement of serum concentrations of total thyroxine, free thyroxine, and TSH made with sensitive immunoradiometric assay did not, except in patients with gross abnormalities, distinguish euthyroid patients from those who are receiving inadequate or excessive doses. These measurements are therefore of little, if any, value in monitoring patients receiving thyroxine replacement. Okay. The serum concentration of TSH is unsatisfactory, as the thyrotropes in the anterior pituitary are more sensitive to changes in the concentration of thyroxine in the circulation than other tissues. So we're talking about the pituitary is highly, again, it goes the opposite direction. As the rest of the body has lower tissue levels, the pituitary increases the level, has higher T3 in the pituitary. So it's clear that serum thyroid hormone and thyroid-stimulating hormone concentration cannot be used with any degree of confidence to classify patients receiving satisfactory, insufficient, or excessive amounts of thyroxine replacement. The poor diagnostic sensitivity and high false positive rate associated with such measurements render them virtually useless in clinical practice. Okay, British Medical Journal, useless. Okay, we consider the thyroid function of little if any value. Further adjustment should be based according to the patient's clinical response. So just more with the author's thoughts. Another study here in British Medical Journal, Mayer investigated the correlation of TSH, free T4, and T3 with, again, tissue levels of thyroid, and it found very poor correlation. There was a better correlation with free T3 and free T4. So talking here that summarized TSH is a poor measure for estimating clinical metabolic severity of thyroid failure. And basically say a judicious initiation of treatment should be guided by clinical metabolic presentation and thyroid hormone concentrations and not by TSH. So let's look at when you suppress the TSH, and this is based on this study, what's the incidence, what's the likelihood that they're hyperthyroid? Okay, and this is basically just kind of normal people, and doesn't hold that they're sick because it's even, those patients have lower TSH. So when you do the sensitivity specificity, the positive predictive value is 23%. So in the study, 23%, if you have that had suppressed TSH, were hypermetabolic or had subclinical hyperthyroidism. But so you have a 80% chance that they're not. Now if they have any chronic illness that lowers the TSH, again this number is going to be exceedingly small. So a couple percent that so TSH does not mean hyperthyroidism. So again, a person being replaced with thyroid that has TSH, suppressed TSH, less than 23% chance of being hyperthyroid. And again, if they have known pituitary dysfunction, which is all those conditions we talked about, you can't use the TSH. Let's look at osteoporosis. With long-term thyroid replacement, with total TSH suppression, and the risk of osteoporosis in postmenopausal women not on hormone replacement is shown to be slight, if any, as majority of studies show no increased bone loss. And again, those are on the site there under osteoporosis and thyroid replacement. In the premenopausal women, studies show no increased risk with total TSH. Again, that's purposely suppressing the TSH. So some of those patients are going to be hyperthyroid. The most extensive review published to date on the risk of bone loss or osteoporosis from TSH suppressive doses of thyroid was done by Murphy and published in Clinical Endocrinology. It analyzed data over 28 studies, so they picked out 20 of the best studies. The author concluded that there was no effect of TSH suppression on bone mineral density in premenopausal women. But again, check that NTX so you can prove what you do. Check it, first visit, and then you follow it, and you'll find that it's lower than when they started. The numerous studies have demonstrated significant risk of bone loss in fractures with SSRIs. It's significant, including large studies published in Archives of Internal Medicine. These studies found that SSRIs, but not tricyclic, interestingly, were associated with double the rate of bone loss and fracture, which confirms a lot of other smaller studies, and is found to be true after adjusting for other risk factors. So, thyroid side effects can trigger caffeine-like anxiety, palpitations, or insomnia. You reduce dose. Always evaluate, are you giving them the correct dose? And I tell patients, what's the optimal dose? Well, it's not a fair question because all the different tissues need different amounts. So you need to evaluate, the patient overall. Beta blockers, cardio calm, magnesium, progesterone, fish oil. And like exercise, someone on the brink of a heart attack, you could, but because of the dilatation, it actually significantly reduced the risk of heart disease, not increased. I think we looked at those studies. But if someone has chest pain, you need to take appropriate action. So what do you do as a follow-up? Continue. You can slowly increase based on symptoms, any incidence of side effects, pulse, body temperature. Watch out for body temperature though, because people with chronic illness have mitochondrial dysfunction, so they don't make any energy, don't generate heat, and you may never increase their body temperature, and even giving them 500 micrograms of T3. So watch out for that as a sole marker. So only check labs increased dose. T3 again. Here's the thing too. What's the normal T3? So T3 norms are for giving. So T3 basically the body makes T4 generally, diffused into the cell, converts to T3, a little bit leaks back into the serum. That's determining the normal level of T3. When you're giving T3, it's going high in the serum and then into the cell. It's a completely different thing. So those normal levels are not appropriate to use when you're giving T3. So here's about we'll talk about AFib. So subclinical hypothyroidism is characterized by increased QT interval. So basically, they're hypothyroid, increased risk for like VFib and fatal arrhythmias. Now here's the study on AFib that everyone points to for about increasing risk of AFib with giving thyroid. So in this study, it's the Salon article in New England Journal of Medicine, and you can see the lines there. The people with low TSH, how they have over years increased incidence of AFib. High TSH is below that. So you think, like, well, if really thyroid was doing it, high TSH would be protective, but it's not. Then slightly low, and then normal. But here's the thing: most of these patients were not on thyroid. And what happens is the sicker the patient, they look at a patient with heart failure. Oh my gosh, the TSH is very, very low. So yeah, of course they're going to have higher AFib. So really, the study's showing the sicker you are, the more likely you're going to be sick and have AFib. But now you look at the patients. This is 2007 patients over the age 60 were studied for 10 years. Now, if you pull up the patients who were taking thyroid replacement after the start of the study, that's 57 patients. So 36 of those, 63%, had a low TSH, but there were no cases of AFib. And there was one case with a normal TSH and 3 with a high TSH. So you look at this data, really shows that it's protective to suppress the TSH. So there were no incidents when you're giving thyroid of AFib with suppressed TSH. Actually, if it was high, was when they got AFib. So really a flawed study, but everyone points to this. But again, don't watch, because you don't want to get blamed, especially if they're older and at risk for AFib. Be careful about suppressing the TSH in an older person. Here's looking at T3 after cardiac surgery, lowers the risk of AFib, not increases. Another study here. Free T3, novel predictor of post-operative AFib. The lower the T3, the higher the risk of AFib. A study here showing that really thyroid is needed to help the remodeling of cardiac tissue after with heart failure or even after heart attack. So here, the study aimed to assess the short-term effect of T3 replacement on patients with low T3 syndrome and ischemic or non-ischemic dilated cardiomyopathy. Significantly improved ventricular performance. Great therapy. If you have anyone with heart failure, check their T3, free to reverse T3 ratio. It's going to be very low T3, very high reverse T3. Give those patients T3, they do dramatically better. And I don't see any endocrinologists doing it, tons of studies on it, or cardiologists for that matter. So here is a study here, low T3 is a strong predictor of death in patients with heart disease. So if they have heart disease and low T3, they're going to die sooner. So community of death here, you have free T3 greater than 3, okay? Slow, not a huge increase in mortality over time. But if they have low T3, you see that much reduced survival. Even mild thyroid problems double the risk of heart disease. So individuals with subclinical hypothyroidism, so normal T4 and T3 levels, which is now termed more mild thyroid failure because the subclinical, most patients really have symptoms, that is detectable only by a blood test are twice as likely to develop heart failure compared to those with normal thyroid levels. So 35-year-old female with 5-year history of hypothyroidism, been on Synthroid 100 micrograms for many years. She calls your office and asks, what's the best type of thyroid replacement? Okay, so is it T3? Is it T4? Is it T4, T3? Well, it depends. What if she feels great? Then, okay, she might be fine. What if she's depressed? Well, if she's depressed, it's unlikely that Synthroid is going to work. T4, T3 probably better, but probably T3 for depressed patients. Studies show significant improvement. Diabetes, same thing. So more likely to need T3. Obese, same thing. Fibromyalgia. So the sicker the patient, the more likely straight T3 is going to be better. So to review, most, if not all patients who are depressed, obese, diabetic, have PMS, are stressed, chronic fatigue and fibromyalgia, older, have chronic illness, are low thyroid, and usually benefit from treatment. Standard reference ranges do not apply if they're on T3. And again, standard blood tests aren't going to really give you an adequate, accurate marker for tissue level of thyroid. The more sophisticated blood tests demonstrate the deficiency. Standard thyroid medications really aren't a good choice. And the standard method of diagnosing low thyroid cannot be relied upon in the presence of chronic illness. Additional methods can be utilized to better estimate the tissue thyroid activity. And really, when you treat this low tissue level, you'll see patients just go, oh my gosh, I've been feeling horrible for years, no one can find anything, getting better antidepressants, told I'm crazy, told I'm lazy, and they just dramatically improve. So, and standard treatment is inadequate for many, and compounded preparations are superior to those that are commercially available. So that's the conclusion of the 3 parts. And if there's any questions, we can go to questions. And so it says, what dose of T3 do you use, and how long until you typically achieve results? So when you look, so everyone's different. You want to typically start low and ramp up. Now again, if someone, let's say someone's on T4 100, then how do you switch them? Well, you can just take them off T4 100 and put them on, maybe 37.5 of T3, 50, 62.5. So generally about half. But it's better. The problem is you're going to be too low for a little bit, too high for a little bit. You don't know. So it's better to maybe cut the T4 in half. Let's say go to 100, drop down to 50, and now then you increase the T3 by 10, 25. See how they do, and right there they'll often feel much better just doing that. And let's see, what would be a good program for a sensitive person who has been on 50 micrograms of T4, such as Levoxel, for 10 years? Let's see, was given only a saliva test and symptoms, but it feels bad if they try to come off of it. To get them off the Levoxel, maybe switching them slowly to T3. Yeah, so that's the same answer I just said, where you want to reduce the T4 and increase the T3. Or sometimes they're just low. You can just add a little T3 to that. But most of the time they'll have high reverse T3, especially if they've been on T4 for a long period of time. The body will start converting it to reverse T3, which, again, blocks the thyroid receptor and decreases T4, T3 conversion, so kind of a vicious cycle. Let's see, it's really hard to do I get to the? Sorry, the question window is so tiny. I can only see one line. Let's see, what would you do for patients who've had treatment for lymphoma and like to build themselves back and prevent the lymphoma from coming back? Well, that's a totally different different topic, and we talk about cancer and immune function. And with the other cancers, you really want to look at natural killer cell function and make sure, because that's the cell that monitors the body for cancer. But with lymphoma, it's a little different because you worry about stimulating an immune cell. Which hormones can be tested with saliva, and which do you need a blood test or a urine test? What opinion? Let's see. What opinion saliva for thyroid hormones and thyroid antibodies, such as one that offer? Yeah. So, question about saliva versus serum. Now, all tests have their limitations, and a doctor we kind of use a lot of serum. We use serum. We don't typically use saliva. It has limitations that we just talked about. Saliva has other limitations. So typically the biggest problem with saliva, the controversy comes in when you're taking such as hormones, let's say transdermal progesterone, and saliva goes very high, serum's low. Is there tissue effect? And this is the big debate. A number of studies show that there's low tissue effect. Other studies show that it's good. So, but it's debatable. And again, all the if someone has saliva tests, we'll look at it. We typically don't do it. We do serum tests. How are you measuring iodine or CRP, or need to balance low adrenals before treating thyroid? So iodine, we use a urine test. We do a spot urine test. We don't do the loading things because of hassle factor. When people come in, we find about 80% of people are low and about 30% dramatically low. And then it says, what about, was it a part of it, CRP? I don't know. Or CRP, or balanced adrenal, yeah. So someone's low adrenal, they may not tolerate thyroid. It's a little overplayed, but someone has adrenal dysfunction, you really need to be careful starting thyroid, which also helps starting real low. We use a lot of adrenal kind of boosters, glandulars. We'll also use cortisol. And if you look on our site, I have a review that I reviewed all the data on HP axis dysfunction, chronic fatigue syndrome, fibromyalgia, and showed that 90+% of those patients have low adrenal function, and treating with cortisol is totally appropriate, has more benefit than SSRIs and all that, sometimes dramatic. Also, you can use the, again, the other nutritional supplements to boost adrenal function. What's the difference between EBV, CRP, serum ferritin, lipoprotein A, and thyroid hormones, including reverse T3? Why is serum ferritin used in your assessment of thyroid hormones, including reverse T3? Let's start. So the I'll go up. Okay, anyone you look at, this is kind of like a chronic fatigue syndrome patient with Epstein-Barr. You're going to get they're going to get a lot of inflammation in these chronic infections. Again, suppresses the T4-to-B conversion, suppresses TSH, reduces transport. So this patient is going to be low thyroid. So they typically need treatment. Again, the sicker the patient, the more likely they need T3. Go up there. So serum ferritin. So again, ferritin we talked about with low iron you get a thyroid resistance. Lipoprotein A. The lipoprotein A is interesting. It's got a basic cholesterol in the cell wall. Increased risk for cardiovascular event. It has to do with coagulation. So it will reduce fibrinolysis. And actually statins make lipoprotein A generally worse. But what does lower lipoprotein A is thyroid and niacin. And so if they have high lipoprotein, they could have a high risk for coagulability, hypercoagulability, and we'll see that with chronic fatigue syndrome fibromyalgia patients. And you can check a coagulation panel. I think there's a seminar on that on our site, and heparin can be a fabulous treatment for these patients. And we'll find, too, is what they do is they'll get what's called immune activation of coagulation. And the infections will set off the immune system, lay down not a blood clot, but fibrin kind of lining the vessels. An option that usually takes 2 seconds to get into the cells can take it to 5 minutes. So all the cells are hypoxic. They get a muscle pain, they get the fatigue, they get the brain fog. And you can break that up, excuse me, with a little bit of heparin and dramatic results oftentimes, or some of the fibrinolytic enzymes, nattokinase, lumbrokinase, we use called Fibrinex. And what you'll find, too, is they get a thyroid resistance, they get a medication resistance, they get a nutrient resistance because it can't get through very well through this fibrin layer. So clean it up. All of a sudden, treatments that you were using that didn't work, all of a sudden they start working. So you really want to check what you check at the D-dimer, thrombin antithrombin complex, prothrombin fragment 1 and 2, PI1, plasmin activator inhibitor 1, which is the most potent inhibitor of fibrinolysis. So you do that panel, and oftentimes it's elevated in these patients and indicates a little bit of heparin, which is very safe, safer than aspirin. Is there any way to get reverse T3 down and address thyroid dysfunction with supplement and thyroid glandulars? Well, you have high reverse T3 typically because of there's some illness in the body. So and that's what, and some of the argument as well, you look at non-thyroid illness, which we talked about in the second lecture, that, oh, you shouldn't treat it because it's not really a thyroid problem. Yeah, it's not. It's a local control problem. So what do? Well, if you get the patient totally well, get rid of their inflammation, their obesity, their chronic infections, their depression, yeah, then you'll be okay. You don't need to treat. But until then, treat with T3. So really, to get reverse T3 down, you need to bypass it and give T3. In your experience, do thyroid patients affected by CFS, EBV infections, virus, and other coagulation defects get better results with time-release T3 or with cytomel, which can be administered in sarcoidosis? That's what we talked about. And some patients you'll read, oh, your time-release T3 doesn't work because they'll typically do, let's say they're on cytomel or time-release T3 50, and they'll go to cytomel 50. Oh, I feel so much better because it's just not as potent, especially in a number of pharmacies with their formula just doesn't absorb, so they're maybe getting 10. So you need to be aware of that difference. I think we saw that. Do Hashis respond better time-release T3 or cytomel? So same thing. You're typically getting a lot less problems. With time-release T3. We find you're not going to get the calls with the palpitations. You can control it much better if you use a lot of cytomel. And that's what for the people that oh my gosh, I got so many people calling because of side effects with cytomel that you're not going to see with time-release T3, and just being prudent and carefully adjusting the dose. Can the cause of thyroid resistance or transfer be determined and corrected, or must the thyroid hormone be taken for life? Yeah, so it's kind of, again, that catch-22 we just talked about, that with the thyroid hormone resistance, yeah, you can get rid of it if you get rid of your illness. But until then, you need to take thyroid hormone. Do large doses of compounded T3 cause weight gain? Well, never seen that. But I never say never, because some people can. I've seen people with T4 get weight gain because they convert to reverse T3, and they go, "My God, doc, I kept going up on my T4 and I kept gaining weight because they're making more and more reverse T3, which is lowering their metabolism." So, but typically not with T3 unless something else is going on. Well, how do you calculate the free T3 reverse T3 ratio? We talked about this in the second lecture. And, so we use free T3 reverse T3 ratio. Yeah, the units are different. It doesn't, for all the engineers out there, they freak out. The units don't cancel. It's, not a problem. You should use T3. Well, I don't care about the units. It's, it's a clinical marker. So generally, depending on the unit, it should be above 2 or 0.2. Matters if they, so free T3 should really be above about 350. And the reverse T3, you look at the studies, and a healthy person is below 150. So there's your 2 right there. So if they're less than that, then consider that they need thyroid, especially the higher that, or the lower the number, the lower the free T3, the higher reverse T3, the more likely you need straight T3. Is it good to supplement with T2? That's interesting. You look at T2, it has some beneficial effects, but it also, suppresses TSH and has some negative effects. So and plus it needs to be really high levels, and so we don't bother with T2. That's a argument that, hey, take Armor because it has some T2 against just thyroid that's just ground up. So, but really minimal effect. How does birth control pills affect the thyroid panel? Yeah, so when you take birth control pills, ethanol estradiol and the progestin, basically, especially the estrogen goes to the liver, increases SHBG we talked about, but it also increases thyroid binding globulin. So what you're going to get is a lot less free hormone. So all those patients are basically low thyroid. Also, it's going to increase inflammation, which again lowers T4 T2 conversion, lowers transport, or low thyroid. So anyone on birth control pills are generally low thyroid. And 2, again, you look at the studies we went through, and I think the second lecture, PMS. Those patients are low thyroid. Give them thyroid, they'll significantly improve. A little thyroid, a little progesterone, like some supplements can help. One we call My Husband Thanks You can be very beneficial. Let's see, any concerns about using Thyroid T3 in a patient with history of thyroid cancer or post-thyroidectomy? Absolutely not. We use straight T3 in all those patients. They do very well. Sometimes we'll add a little T4 back. They 50 of T4 and go up. But those patients are often put on, they get a thyroidectomy and the doctor says, oh, you'll be fine. Oh my God, they're miserable. That's a huge part of our practice. They gain 20, 30 pounds. The doctor says, oh, that's normal after thyroidectomy. How can that be normal? How can that be giving normal replacement if they're gaining on average 20 to 30 pounds? So they definitely need more T3, and they typically need higher, certain grades especially needs higher levels of T3 after it's been treated, either downregulation receptors or something. But so those patients definitely need T3, and straight T3 is we use a lot in those patients. Sometimes it's around high dose. You can add a little T4, but you don't need to. I've heard some patients need 2 to 3 months of therapy goes and they feel better. Have you seen this kind of delay? It depends. I mean, some patients feel better in a couple days, and a couple weeks. It's variable. It depends on how fast you ramp up to the optimal dose, and also not everything's thyroid. Thyroid, if I can have any one treatment, give me thyroid. But you also have to look at other things and look at the other hormones and other chronic infection, coagulation, mitochondrial function, sleep, gastrointestinal dysfunction. So this is a great tool, and I think you're going to find so many patients just really improve. But you also got to treat the patient as a whole. So just like I said, will be the last one. What would you recommend as a nutritional protocol to support thyroid, other meds, selenium, iodine? Yeah, so you want to make sure their iron's good. Selenium, we like a protocol that has forskolin in it. We call it ThyroRx. That kind of has other things in there. Vitamin D is important. All those things. So yeah, a lot of nutritional support, but in general, for the thyroid, iodine, iron are a couple key ones. Vitamin D more for the Hashimoto's. And iodine also, when you look at what's the tissue that uses iodine most, thyroid, number 2 is ovaries. So with low iron, they'll often have poor progesterone production, and also you'll get cyst formations, a lot of times from low progesterone. So yeah, all those are important as well. So I think that will conclude. We're out of time. I appreciate everyone joining. And again, we have the other two. I hope you listen to those beforehand. This would make a lot more sense. And I appreciate it, and thanks for the opportunity.
Thank you very much, Dr. Holtorf. All 3 archived events will be available on the BHI website. So that's www.bioidenticalhormoneinitiative.org. We'll also post some information like where you can find Dr. Holtorf's references and other information. So please stay tuned, and thank you very much for joining us today.